Good evening, everybody, and welcome to what is the last week of this special series which we've organised relating to lifestyle and COVID-19. Over the last 3 weeks, I think we've had 6 different talks in all areas of lifestyle with exercise, diet, and how they relate to COVID-19. So I hope for those of you who've attended those talks that you've found them useful and have enjoyed them. Tonight we've got 2 more talks. The first talk tonight coming from Professor David Broom, who's an academic at Coventry University, and that talk will relate to physical function in vulnerable adults, specifically with considerations for COVID-19. So David will speak for, I think, around about 45 minutes, and then we'll have a couple of questions before Dr. Florence Kinnafick will take over, and she'll talk about mental health considerations during the COVID-19 pandemic. And again, Flo will talk for around 45 minutes, and then we'll have a larger question and answer session at the end. And with regards to questions, as always, please do send your questions through on the chat function at any time during the talks, and our moderators will pick up those questions and make a note so that we can put them to the speakers when they have finished. I guess with regards to housekeeping, please, if you can keep your microphones muted and video switched off, that will help with the bandwidth. And obviously, if you do put your microphone on and say something, you might get recorded, as these talks have been recorded each week and will be available after about 2 or 3 days on the National Centre for Sport and Exercise Medicine website. I should say that I think in a couple of days' time, you'll also get an email with a link to provide some feedback via a survey. So if you do have time, please give us some feedback so that we know how we might be able to set up some more talks going forwards, hopefully in a way that everybody enjoys. So I won't rabbit on for any longer. I'll introduce Professor David Broom. And David, let you take it from there.
Thanks very much, James, and good evening, everyone. So as James says, I'm David Broom. I'm one of the non-Loughborough people that's been invited to talk. So firstly, thank you very much. I feel very privileged, but I've got a long-standing relationship with Loughborough, having done my undergrad, masters and PhD there. So COVID-19 is an unprecedented health crisis where entire populations have had to isolate, and this in itself is leading to quite a large physiological challenge that has numerous health risks. And I'm going to talk about some of those today. Now, the focus of my talk is obviously on the general population, focusing specifically on vulnerable adults where possible. So I'm not so much going to talk about the rehabilitation of COVID-19 sufferers, but in terms of my discipline, this shows that exercise science, physiotherapy, the demand for these types of roles is also unprecedented. So I'm, of course, going to present some research evidence. I've got, no doubt, quite a wide audience. I'm going to try and juggle some kind of simple messages with academic rigour. But as a presenter, what I try and do is give personal experience and anecdotes to kind of bring that content to life. And hopefully with some of my humorous examples, you can relate to this stuff. So first slide, just a little bit about me then. And I must say that the image there should come with a little bit of a footnote. This picture was taken prior to me having 2 children, and certainly during, before lockdown. So I'm looking a little bit less tired there. As James said, I'm a recent professor, 4 weeks in, and I'd obviously like to thank Coventry University for bestowing me that honour. I'm also the chair of BASES Division of Physical Activity for Health. BASES is the British Association of Sport and Exercise Sciences, and we've convened a special interest group for COVID-19 that's headed up by Professor Andy Smith, and we're also writing guidelines for returning to the lab and to facilities. So for more information on that, please visit the BASES website. I was very privileged to be invited to the Chief Medical Officer's expert working group to update the physical activity guidelines that were published in 2019. And all in all, my grant income as principal investigator and co-investigator is in the region of around about £1 million. I should declare that I have consultancy roles with Clearcast and Well Professor. I've also received recent funding from Sport England and Grow MedTech, but I have no conflicts of interest with regards to this presentation, and none of this funding will bias any of my opinions as part of it. So in terms of the webinar structure, first I'm going to give you a little bit of context and background information. I'll then highlight the declines associated with excessive sedentary behaviour. Thereafter, I'll highlight the importance of maintaining fitness for optimal physical function, define the principle of reversibility, and then the last section, which I think is ultimately the most important, is to provide you with some simple messages, activities and interventions that you can use to overcome reversibility. I'm calling this the key take home, and the pun is intended because no doubt many of us are going to be operating currently in our homes. So in terms of the context, and from our previous speakers and those that have attended the other seminars, and hopefully I'm preaching to the converted now, is that physical activity and exercise will improve blood glucose and insulin sensitivity, can improve blood pressure, reducing the systolic and diastolic blood pressure. It can improve body composition through reductions in fat mass and an increase in fat-free mass, improve blood lipid profile in terms of reduced total cholesterol, low density lipoprotein and increased HDL cholesterol, improved immune function, and it can also, in the focus of my talk, increase muscle mass and strength, greater oxidative capacity, as well as improve physical function and mobility. So that's the benefits of physical activity. But as we know, COVID-19, we were put into a government-imposed lockdown where we're only allowed to leave the home for 1 hour per day with immediate family and to stay within a limited distance. And of course, leisure facilities, gyms, swimming pools, parks, and so on and so forth had to close. Now, during this lockdown, there has been an abundance of physical activity and dietary surveys. And in my role as chair, I've been asked to kind of showcase and send out numerous. And while some of the data is emerging, just at lockdown, you know, my hypothesis was that for your typical person, there's likely to be a decrease in overall daily physical activity, an increase in sitting time, and an increase in energy intake, predominantly through increased snacking behavior. I'm presenting in my kitchen and my fridge is just there, as well as an increase in alcohol intake. Now, actually from personal experience, there's been a strong correlation between hair growth and waistline growth. In fact, I'm even having to use my other half's headband now. Through correlational studies, you can't establish cause and effect, but in all seriousness, you know, even though I'm an expert in this thing, you know, I've put weight on, okay, and I'm sure I'm not alone in that. I do say the typical person because there will be instances where actually some people will have really made a conscious effort to increase their physical activity. Of course, that can happen, and I will, in section 5 of my presentation, be presenting some ways in which we can increase our physical activity behaviour during lockdown and of course, once we're out of this thing. So let's have a look at some physical activity statistics and trends. And this is data from Sport England. And activity levels were reported to be on the rise and inactivity was falling before the coronavirus outbreak, according to the Active Lives Adult Survey. 63.3% of the nation's population were active, up 404,600 compared to the previous 12 months. Of course, we do need to consider this is a survey. Okay, so there are some issues with regards to self-report, but some other data, almost 2/3 of adults consider exercise to be more important than ever during the current coronavirus crisis. And in terms of Flo's talk, reassuringly, 65% also believe exercise is helping them with their mental health during the outbreak. More on that later. With regards to some objective data then, and this data was released a few days ago by Fitbit. Okay, Fitbit is obviously a physical activity tracker, a wearable device. And if we look at some of the changes in step counts prior to the coronavirus lockdown and now, if we focus on the Great Britain there, roughly in the middle of the slide, a -9% step reduction. I think the worst case in terms of a global picture is Spain there with a reduction in 38%. Now, again, we will have to interpret this data with a little bit of caution because, of course, the owners of Fitbits, these are quite expensive pieces of kit. That tells you something a little bit about the socio-economic status of the users of Fitbits. In terms of the determinants of physical activity, and we've got some quite stark inequalities that, of course, have persisted during the coronavirus lockdown. In terms of age, younger groups are more likely to have done more physical activity in the past week, 43% for those aged 16 to 34 years, compared to 22% of those aged 55 plus. In terms of social background, people in higher socioeconomic groups, ABC1, more likely to have done more activity in the past week than those in lower socioeconomic groups at 34%. For ABC1 groups, 27% for C2DE groups. Finally, in terms of urban versus rural areas, people in urban areas are more likely to have done less activity in the past week than people in rural areas. 43% of those living in urban areas versus 53% of those living in rural areas. Back to some Sport England data. And again, from a recent survey, when they asked the question, in the past week, do you think you have done more, less, or the same amount of physical activity and exercise compared to a typical week before the COVID-19 restrictions? We can see that the orange line is representative of less, starting at around about 40%, and fairly similar, going down to around about 37% there at survey wave 6, compared to the blue line, who think they've done more. Few people thinking they've done more physical activity, but a prevalence of around about 30%. And those neither more or less with the purple, around about 25% there. In terms of sedentary behaviour then, so to my knowledge, there is no specific data that's been released yet on sedentary behaviour. I'm always happy to be proved wrong, and if anyone has actually found some actual hard data, please feel free to email it to me. My email address will be at the end of this presentation. But if we actually look at the latest figures for COVID-19, the latest prevalence figures show that 23,459 people in the UK currently have symptomatic COVID symptoms. So actually, as a proxy measure, I would argue that probably the large majority of those people are going to be sedentary. Okay, and as I've hypothesized, I do feel that people's sitting time will have increased. So I think we can be confident to say that for your typical person, sitting time and sedentary behavior will have increased. So what is sedentary behavior then? So sedentary behavior is any waking behavior characterized by an energy expenditure of less than or equal to 1.5 METs, whilst in a sitting, reclining, or lying posture. And I just want you to have a look at this slide here and consider whether, actually, is this typical of a day before the COVID-19 lockdown? All right. So this is a hypothetical situation where a person wakes at 7 o'clock in the morning. They have their breakfast with their family, sat down. They then drive to work. They get to work and they sit down at a computer and they work for 3.5 hours. They then go and join their colleagues for lunch at the canteen and they sit down for lunch. They then go back to their desk for the afternoon and they work at their desk for 3.5 hours. They then get in the car, drive home. They, because I'm a southerner, they sit down and they have their dinner with their family. They then watch TV for a few hours before going to bed at 11 o'clock. Now, at some point, and I've placed this, it might be to, after the TV viewing of an evening or to break that up, they do some exercise for 30 minutes. Now, how we would describe that person, we would describe that person as active because they have met the physical activity guidelines of 30 minutes, and that person in particular looks like they're out running, of moderate intensity physical activity. Well, actually, the large part of their day has been sedentary. And we call this the active couch potato phenomenon. Now, when we consider the COVID era, and then we think about being in lockdown and other types of sedentary behavior that people could undertake, such as online shopping, video games, reading, sat down listening to music, and by its very nature, with gyms and leisure centres closing, people potentially just going out for walks and ultimately reducing the intensity of physical activity that they've undertaken. This is potentially what sedentary behaviour in the COVID era looks like. So what is the impact of sedentary behaviour? And this is probably one of the more complicated slides that I'm going to present. So if you could just spend a few moments just eyeballing the figure. So what this figure is demonstrating is the risk of all-cause mortality. So all-cause mortality is dying from any cause, and the risk ratios for sitting time for adults. On the x-axis at the bottom, you have sitting from 1 low to 5 high, 5 being most of the time, 3 half of the time, 1 for not much of the time. On the y-axis, you have the risk of all-cause mortality from 0 up to 2, and a risk score of 1 is allocated to the relative score. The inactive group is denoted by the red bar, and the active group is denoted by the yellow bar. So firstly, if we look at some of the trends, we can clearly see that in both the inactive group and the active group, as sitting time increases, your risk of dying from any cause also increases, regardless of if you're in the inactive group or the active group. The worst case is obviously to be in the inactive group that sits for the highest amount of time, with a risk there of 1.8, so an 80% increased risk of dying from any cause. Interestingly, if you are active but sit for a lot of the time, that is still damaging and increases the risk of all-cause mortality. So even if you are active, sitting for a lot of the time can drastically increase your risk of dying from any cause. Now, this study was presented by Kaczmarzyk and colleagues. It's quite an old study now, 2009, but this was one of the seminal papers, if you like, that kind of brought this idea to life. And there's been a lot more publications, some actually disproving this and showing that physical activity can be protective, but I would argue, and still personally from expert opinion, that too much sitting time is bad for you. And there's a number of reasons for that. And again, I would just like to draw your attention to this paper that was published very recently in the European Journal of Sports Sciences, entitled "The Impact of Sedentarism Due to the COVID-19 Home Confinement on Neuromuscular, Cardiovascular and Metabolic Health." And I would encourage you to to go and read this paper. It's extremely comprehensive and gives a lot of the science as well as some of the mechanistic content that I've not so much focused on in this presentation. But some of the real key messages from this paper is that muscle wasting occurs rapidly and is detectable within 2 days of inactivity. Just a few days of step reduction or bed rest reduces insulin sensitivity, principally in the muscle. Aerobic capacity is impaired at all levels of the oxygen cascade, from the cardiovascular system, including the peripheral circulation, to skeletal muscle oxidative function. And positive energy balance during physical inactivity is associated with fat deposition, associated with systemic inflammation and activation of antioxidant defenses, exacerbating muscle loss. So on this slide, if you could focus on the figure at the top, and of course, through the normal aging process, we are going to experience muscle atrophy. And as we age, we achieve around about 100% of our lean body mass, our muscle mass, at around about the age of 25 years. And this declines thereafter from 40 years to 70 years, around about an 8% loss per decade. 70 years to 80 years, we see around about a 15% loss. If I could draw your attention to the bottom left, if you see the loss of lean body mass is due to aging and inactivity as a result of decreased protein synthesis. Illness and injury can also lead to a loss of lean body mass. And what's happening during the pandemic, the isolation, increased sedentary time, people are going to be losing lean body mass. And if we look at the cutoffs and the associated complications, a 10% lean body mass loss can decrease immunity and increase risk of infection. So that in itself is quite worrying in terms of the COVID-19 pandemic. A 20% lean body mass loss decreases wound healing, increases muscle weakness, and increases risk of infection. A 30% loss can lead to a difficulty in sitting, pressure ulcers, pneumonia, and an inability to heal. And a 40% loss can increase risk of death, usually from pneumonia. And if I just refer back to the paper that I presented on the previous slide, it's quite clear that obviously during this pandemic, even healthy and fit individuals, if they drastically increase their sedentary behavior, can see lean body mass losses of around about 10%. In the previous few months. And there's some studies emerging as well that those COVID-19 sufferers who are coming off ICU wards may have lost lean body mass of around about 15% and are potentially becoming type 2 diabetic as well. So it's quite frightening. And confounded by this loss in lean body mass, there's also real links with osteopenia, which of course can also increase the risk of osteoporosis as well. So as well as lean body mass losses, we can clearly see some issues in terms of reductions in bone mineral density and content, and even some quite severe bed rest studies have shown that spine bone mineral content can be reduced by about 2% as a result of 7 days bed rest, as a more extreme measure. So where does this all fit in then in terms of physical function? And it's very important that we think about our function in order to be able to undertake tasks of everyday living in order to live independently, particularly for older adults who might be considered vulnerable during this crisis. And if we look at this figure, and I'm just going to kind of give you, this is a hypothetical figure. If we have age in years on the x-axis and an exercise performance task on the y-axis, if you look at the person that's represented by this solid orange line, as we age, we might expect our capacity to perform a task increases up to a certain age, then it begins to fall, and the white dashed line is represented of a threshold value necessary for performing an everyday task. If we compare that to a physically active person who is active, they might be undertaking some strength activity, aerobic activity for whatever performance task. Their capacity to achieve that performance is greater, and therefore they will experience a decline, but the age at which they reach that threshold value is greater than the person who is physically inactive. So let's bring that to life with a real life example then. So if we take a very simple task from everyday living, something as simple as opening a jam jar. Okay, so let's firstly consider our inactive person who doesn't perform any strength activity. Okay, they, of course, as they age, they're going to experience some improvements, but the decline begins at an earlier age, and the threshold at which they can't open the jam jar is reached at an earlier age compared to the active person who undertakes their strength activity, and they can open their jam jar at a far later age. So something as simple as that, can actually keep somebody living in their own home because they can open a jam jar. If we look at some other measures, such as knee extension strength, and this is quite old data now from Skelton and colleagues, published in 1999, but it's really, really fundamentally important to this day. And they measured knee extension strength in various different populations, age 50 plus. And again, if you have a look at the figure, age in years on the x-axis, isometric knee extension strength on the y-axis. On the left-hand side, we have the male data, and on the right-hand side, we have the female data. If we look at the trends, we can see in males that knee extension strength declines from the age 50 down to 70. It also declines in females for the same age groups. And we see higher knee extension strength in the males compared to the females. Now, if we focus on the dotted white line, which is the strength to be confident of rising from the low chair without using one's arms, actually what we can see here is that your average, your typical, certainly 70 to 74-year-old male and female can do that. But if you look at the kind of the variation, this is the standard deviation, there is some of that population that is not going to be able to rise from a chair unaided, okay, because of a lack of knee extension strength. And that is really, really important in terms of doing something simple like getting off the toilet, okay? If they're below that threshold, that they're at increased risk of living in a care home. There are some quite simple assessments that you can do to identify people who are at low risk of low strength. If you have a hand grip dynamometer, which is less likely, a grip strength of less than 27 kilograms in males and 16 kilograms in females is a red flag. A test that you should be able to implement very simply and in the home is the sit to stand test. And if somebody takes greater than 15 seconds to do 5 sit to stands, anyone meeting these thresholds is a cause for concern. They're likely to have limited physical performance, reduced independence and quality of life, increased risk of falls and fractures, increased need of healthcare services and support for activities of daily living, and an increased risk of multimorbidity and mortality. In terms of aerobic capacity, data from the same paper, the same research group, again, age in years on the x-axis, maximum oxygen uptake this time on the y-axis, males on the left-hand side, females on the right-hand side. Trends, males and females, maximum oxygen uptake decreases as we age, and we can see the dotted line that is represented by a threshold, which is the VO2 max to walk comfortably at 3 miles an hour. And to put that into context, that's the VO2 max that would be comfortable to be at a pedestrian crossing, and when the light goes green, you can get across the pedestrian crossing before it goes red. Now, if we see your average 70 to 74-year-old male is above that threshold, your average threshold can do that. Actually, your average 70 to 74-year-old female is unable to do that. If we use this task of trying to cross the road before the green man goes red, and when we think about all of the components of fitness that are needed to do that, in terms of strength, we need the strength to overcome the resistance of picking up a heavy bag, muscular endurance to maintain the isometric contraction needed to carry the bag all the way home, and finally, power to exert force quickly enough to get across the road before the green man disappears. Now, again, if we think about some of the content that I've presented, and we think about some of the declines that happen into lean body mass, and therefore strength and power and muscular endurance, as well as declines in aerobic capacity, already before COVID-19, there was a paper to demonstrate that most older pedestrians are unable to cross the road in time. That's going to be more of an issue once we get out of lockdown, and is a real problem in terms of older adults returning to real life, not being able to potentially cross the road safely. That can lead to fear, that can lead to isolation, that can lead to further declines. Even if they hurry across the road, that could lead to a fall and a fracture. So there's real issues, particularly with vulnerable older adults. Reversibility. So effectively, what my talk has tried to highlight is the principle of reversibility. And that is, if you stop being active, you will lose the associated benefits. And in terms of a simple message, you might have heard of the use it or lose it phenomenon. And this will occur regardless of if you are inactive, active, or an elite athlete. You will experience deconditioning if you do not maintain physical activity and stimulate the muscles. But it's not all doom and gloom. And again, in terms of some data, if I could draw your attention to the figure at the top, panel A, of course, as we age, this just demonstrates that we can see a reduction in muscle cross-sectional area. And panel B shows the decline in the relative contribution of type 2, known as the fast twitch muscle fibers. Importantly, if we look at the figures at the bottom from C to E, figure C is a cross-section of the quadricep muscle of a 24-year-old male who has a body mass of 76 kilograms. And we can see there quite limited fat mass, which you can hopefully make out is the kind of the white stuff around the outer of the quadricep muscle, with a fat-free mass of 57 kilograms. That just gives you something, a picture just to have a look at. Compare that to D and E, both male, 66 years. But if you look at figure D, body mass of 81 kilograms, similar to that of the male in figure E. Fat mass of 57 kilograms, average daily steps of 3,141, with a physical activity level of greater than 3 METs per day. So that's what we might see as known as moderate intensity physical activity for only 22 minutes. Compare that to the person, figure E, average daily step count of 12,445. Yes, substantially more than the physical activity guidelines at 130 minutes of physical activity at greater than 3 METs, which is moderate intensity. But again, it shows that that level of activity can actually preserve fat-free mass. So what do we need to do then? Okay, and this section is going to look specifically then at some means and ways by which you can promote physical activity. And we're presenting on behalf of the National Centre for Sport and Exercise Medicine in the Midlands. And there is also a national centre up in Sheffield. And the guys in Sheffield, they actually compiled a leaflet. You can see this on the left-hand side. And this leaflet, very simple, was just presenting the physical activity guidelines. That was distributed to approximately 25,000 homes in the Yorkshire region. It has been picked up by Public Health England now and distributed locally. So if you're interested, you can see the web link just below the purple promotion text there. Sport England, a few days after lockdown, created a website called Join the Movement, #StayInWorkout. And if you visit the website there, that will give you a whole host of ideas about being active at home, as well as links to kind of apps and fitness gurus who have been running various different physical activity sessions. I think it's really important to present simple messages. And this was one of the clear messages from the European Journal of Sports Science paper that I presented previously. And that is low to medium intensity, high volume resistive exercise, easily implementable in home settings, will have positive effects, particularly if combined with a 15 to 25% reduction in daily energy intake. Okay. And, you know, you can do resistance exercise in the home if you use simple means. You don't need a gym, you know, even something as simple as a tin of beans or a bag of sugar, particularly in an older adult population, that can be used to do bicep curls as well as other different resistance exercises. Some is better than none, but more is better. And that is the cornerstone, if you like, of the message from the Chief Medical Officer's guidelines that we published in 2019. So it's really, really important to just do some activity as much as you can, you know, even breaking up sedentary behaviour by any means possible. But of course, more is better, more high intensity physical activity. And the message I like to promote off that is that no pain, no gain is insane, as you will get some benefits from low intensity physical activity. It's important, particularly with an older adult population, that we put a different, what I call a different spin on fitness. So, you know, it's not about having the strength to lift, you know, 100 kilogram dumbbell, for example, or bar. It's about having the strength to lift household objects, flexibility to wash the hair and tie the shoelaces, balance and agility to climb stairs and change direction, coordination and dexterity to open a door with a key, the speed to cross the road at a pedestrian crossing, or the aerobic capacity and muscular endurance to walk to the shops and back home carrying the shopping. So how can we be more active then? And what are some of the things that you can potentially promote or recommend? So these, if you like, are my 10 ways to be more active during the day that doesn't involve getting off the bus one stop early. And it always makes me laugh when I see that message promoted, because who in their right mind, after paying their bus fare, is going to get off the bus one stop early? I've actually yet to see a study. I should probably do a search for one, but I can test that anyone would do that. But anyway, here's some ideas. So, you know, the first thing that I like to do when I wake up is get a cup of tea. And while the kettle's boiling, if you hold on to the kitchen side and do calf raises and half presses, there's your first muscular endurance session of the day. And if, like me, you drink multiple cups of tea or coffee throughout the day, you can squeeze those in. Hopefully something that you do twice a day is brush your teeth. And when you brush your teeth, if you stand on one leg whilst brushing your teeth and then swap to the other leg halfway through, that's 2 really good balance sessions that is going to drastically reduce your risk of falls as well as osteoporosis in the lower limbs later in life. Walk, jog, run or cycle when you return to work, to get to work and to return home, even if it is part of the journey. And this will certainly contribute to meeting the 30 minutes per day of physical activity, moderate intensity, if you do so at a suitable intensity and pace. Use a pedometer, activity monitor, or smartphone app to record your number of steps. And there's good evidence to show that actually if we track and monitor our physical activity, that encourages us to meet a physical activity goal. Or for example, if you have a pedometer and the message that we're told is 10,000 steps, now actually 10,000 steps is far greater than doing 30 minutes of physical activity. It will take you longer than that to do 10,000 steps. It's a message that's simply been promoted. But if you've got one of these pedometers or monitors and you've not achieved that, then there's a greater chance that you will try and accrue those steps. Certainly with people that I work with as a goal, 10,000 steps is extremely high. Tell people to try and increase their daily step count by 2,000 steps. That has been shown to be clinically meaningful. Certainly any step counts of less than 5,000 steps, can put you at increased risk of non-communicable diseases. So it's important to try and aim for at least above 5,000 steps. Whether you're at work, home, traveling on a train or plane, obviously not in recent times, do not sit for long periods because of the various dangers that I've associated with sedentary behaviour. And even some research that I've undertaken with other academics has shown that even if you break up that sedentary behaviour with light intensity or moderate intensity walking for 2 minutes, that will significantly improve your what I call metabolic fitness, insulin sensitivity and glucose metabolism, without leading you to eat more or increase your energy intake on that day. If someone calls you on the office or home phone, stand whilst talking. If you get a call on your mobile phone, pace up and down or walk on the spot. If you have a one-to-one meeting, stand or walk and talk for the entire meeting or for at least 5 minutes. And when you've got a mountain of work and looming deadlines, I'm guilty of this, it's very tempting to eat your lunch at your desk and not take a break at all. If you can, have an active lunch break, get up, move about, even if you walk to the canteen or walk to the shop to buy your lunch, try and move. If you don't want to drift too far from your desk, just have a move around, have a shake and have a stretch. Peer support is absolutely vital. And evidence shows that you will be more active if you involve friends and family. And certainly I found during lockdown that during that 1 hour's time as a family, we have gone out and we've gone for a walk. Actually, we didn't realize we've got a cemetery that's quite near us, and we've gone out most days and had a walk for an hour just to allow our youngster to run off a bit of steam. Another message, bit of a quirky one. If you've got a dog, take it for a walk. If you haven't got a dog, take it for a walk anyway. Highlighting the real benefits of even walking in and around the home, in the garden, or for that limited distance around. Walking really, really is good for you. And how could I forget? Please take the stairs if you can do so and whenever you can. So in terms of some of the other benefits of physical activity and reducing sedentary behaviour, and hopefully this will provide a nice lead into Flo's talk, mental health is really, really important. And I have alluded to this through my talk. I have got a young family and there have been tantrums in our house. And myself and my 3-year-old have tried to calm down my other half as much as possible. But look, it's been extremely challenging, hasn't it? You know, trying to juggle childcare, work, as well as keeping fit and being confined. So, you know, COVID-19 has definitely highlighted the importance of physical activity for mental health. Chocolate is the #1 crave food in the UK. And again, my other half, I think, through this lockdown, has kept a well-known chocolate manufacturer associated with the colour purple in business. But again, there's some nice evidence to show that physical activity and exercise can actually reduce your cravings for certain foods. And an area of expertise of mine, as well as James King, who provided me that nice introduction. You know, we do explore the effects of exercise on energy intake, and there's definitely more work that needs to be on that. One of the things that has emerged from the COVID-19 lockdown as well is that it's impacted on people's sleep. Physical activity and reducing sedentary behaviour will help you improve both the quality and quantity of sleep. During the lockdown, I think fitness and nutrition gurus have somewhat reveled in terms of providing daily YouTube, Instagram, and I think TikTok is it has become very, very popular. And don't get me wrong, I think there's a place in terms of physical activity for that, but it's by no means a long-term solution. And to my knowledge, certainly for COVID sufferers, there's no effective or evidence-based, effective or efficacious home-based exercise program. So an absolute shameless plug on my part is one of the things that I'm looking to do now, and this is out for recruitment. If you know of a budding PhD student, please get them to have a look at this opportunity here. I've called it Project Way. We are active and in this together. And what I plan to do with this program of research is to co-design and co-develop a home-based physical activity intervention that can hopefully scaled up and implemented nationally. So if you're interested, please have a look and direct that to other people using the web link below. So I have just hit the 45-minute mark. I'm bang on. So I'd like to thank you for your attention. A quick funny there in terms of the remember when he used to carry a scythe. My email address, if you would like to follow up with me after this talk, is ad5173@coventry.ac.uk. I would also like to thank and acknowledge the contribution of a good friend of mine, a really good researcher, Dr. Tom Madden Wilkinson, who's a muscle physiologist, and he provided some of the slides for the more lean body mass related content. Thank you very much.
Brilliant, thank you for that, David. That was an excellent talk, a nice blend of academic content with lots of clear practical messages as well. Esther, are you switched on?
Yeah, I am indeed.
Did you get some questions come?
Yes, we've got a couple of questions now. So if anyone has any more, keep them coming in, and we will ask them at the end of the session. So, David, what would you suggest as a simple message to promote physical activity in the older population? It's very difficult to attain a simple message to highlight strength and aerobic exercise in this population.
Yeah, I think the cornerstone message of the Chief Medical Officer's guidelines is, some is better than none, more is better. So in terms of an older adult population, they're not a homogenous group, okay? Whilst we are going to have older adults that are extremely active, we are going to have the oldest old that are quite frail as well. But any movement or activity, even if it is aided activity in terms of movement and you have to get support in the frailest frail, will have a whole host of benefits in older adults who are predominantly sitting down in terms of reducing gravitational edema, swelling, and reducing fecal impaction, and so on and so forth. any movement. Get up if you can do so and move about. You know, in terms of the physical activity guidelines, in terms of the sedentary group weren't able to put a specific time on how frequently we should get up and move. But as somebody who's done a lot of reading in the area, if I was to put a value on it, get up and move every 20 minutes at least.
Fantastic. And then one more coming from James King about Sport England's stats on physical activity. Were they self-reported, as the values seem quite high, and probably would be much lower if accelerometers were used?
I can tell you now the data I'm sure would be much lower if we used accelerometers. So of course we have to take into account that you know, the data was from the Active Live survey, which is a online completed questionnaire that's often completed by around about 2,000 people and then scaled up. But interestingly, in a survey in 2008, when they actually put accelerometers on people, actually they found values of around about 10% in males and 8% in females that were meeting the physical activity guidelines. So of course often with self-report, physical activity levels are grossly overestimated.
Brilliant. Thank you, David, for that. So we'll leave that there for the time being, and we'll pass over to Florence.
I'll stop sharing.
Is on. Are you there, Flo?
Hello, hi. I'm just unmuting myself and starting my video, and then
I'll just remind everybody then that Flo is a senior lecturer in the School of Sport, Exercise and Health Sciences at Loughborough, and Flo's an expert in behaviour change, physical activity, and mental health. I'm sure Flo's title is a bit more specific than that, but I'll let Flo introduce herself a little bit more specifically now. Over to you.
Thank you, James. If I just, okay. Hi, again, really happy to be here to be able to speak to you all. Much like David, I've got a 1-year-old who's downstairs and I can hear him sometimes. So I do apologise if you start hearing him as well, but I think that's kind of life for everyone at the moment. So I'm Florence Kinnafick, and I'm going to be talking to you today about COVID-19 mental health and some of the considerations that we should be making, and specifically in my area of research. So to introduce myself, to begin with, so I'm a senior lecturer in exercise psychology in the School of Sport, Exercise and Health Sciences at Loughborough University, and also work within the National Centre for Sport and Exercise Medicine. So I'm a psychologist by background with the British Psychological Society, with a special interest in exercise psychology. And so my research specifically focuses on physical activity, those psychosocial determinants of physical activity behaviour. And I work with individuals who have mental health problems and mental illness. Specifically kind of looking at what can we do with interventions to promote physical activity. And there's a whole host of research coming out in terms of intervention, development, implementation and evaluation, and kind of really what are the nuances of all of those things that we can do to make interventions effective, because there are so many interventions going on, but we need to learn from those and how to do them effectively and appropriately for the population groups that we are targeting. And so physical activity and mental health broadly, that's my area. And also some partners and collaborators that I'm working with at the moment is Mind, so the mental health charity that we're all very familiar with in this country. So we're leading on their evaluation of the Get Set to Go programme, which is a nationwide physical activity programme, which is a peer support programme for those who are associated with Mind and have mental health problems themselves. Also, I'm evaluating a Sport England funded England netball, so many Englands, England netball project for older adults as well. So leading on from David's talk, older ladies walking netball program, so the effectiveness of that. And that's with the aim of reducing isolation, very important for older adults. Also work with St Andrews Healthcare and Rampton Hospital, that are both secure psychiatric units, so low, medium and also high secure. So again, promoting physical activity on the wards, a very different, unique context there for promoting physical activity. So today in this presentation, I'm going to touch upon the concerns for mental health during COVID pandemic. We're kind of some way through, still a long way to go. And these concerns are from individuals who have mental health problems, individuals who have mental illness, but also from the general public, but also health professionals as well. I also want to look at some of the emerging evidence, but importantly, touch on existing evidence that can help us understand mental health through this pandemic. And then lastly, I think following a nice format from David, I'm going to look at some practical considerations of how we can mitigate individuals' mental health issues. And they are by no means exhaustive, so it's pulling on some of my research area of how we can start to think about that, specifically physical activity, social connection, and restoration through exposure to green space. So before I start, I want to kind of go over where I'm coming from when I use the term mental health. I think in society, the words mental health are used in lots of different ways, and the meanings behind how people use them. So when I'm talking about mental health, I'm talking about mental health as a complete state and not just an absence of illness. So this figure by Keyes, I think, really illustrates nicely how mental health is dynamic, and it can change as we progress through life and experience different things, and how different stresses can put pressure on our ability to cope and be resilient. And that's regardless of our mental illness status. So we can be flourishing, we can have good mental health with or without a mental illness. And similarly, we can languish and experience some mental health problems with mental illness or not. So I think mental health as a complete state, we all have mental health, and it is this dynamic process. So that is where I'm coming from when I talk about mental health. So before the pandemic, the statistics that we've been provided with relating to the prevalence of mental health problems, so that 1 in 4 is pretty well known in terms of 1 in 4 people are affected by a mental health problem in any 1 year. And it's estimated that 1 in 6 of us will experience a common mental health disorder, and common mental health disorder like depression or anxiety in any 1 week. Also now, mental health problems is the main cause of overall disease burden worldwide. And those who do have mental health problems or a diagnosable mental illness have a reduced life expectancy of up to 20 years. And this is largely down to physical health inequalities. So those who have poor mental health or mental illness are more likely to have cardiovascular disease and metabolic disease such as diabetes, respiratory disease. They're 4 times more likely to smoke, more likely to engage in risky behaviours, and also on medication that some can further exacerbate some of those issues. So mental health is already a considerable public health concern and importance, and this is expected to worsen during the pandemic as we progress, and potentially for a while after, when there is control over the pandemic. And this is for those without illness, and also worsening symptoms potentially for those with mental health problems or an illness already. So as David alluded to in his talk at the beginning, we are living differently and have been living differently for the last few months, with shielding, self-isolation, lockdown, continued social distancing, which will continue in the future, and also exposure to infection. And each of these different ways of living will put stresses on different individuals and in different ways. And it's up to us, and it will continue to, as as we progress through this pandemic. And so it's up to us as researchers, policymakers, government, healthcare teams to really understand kind of how each thing can affect different individuals, and who to be able to address those stresses on individuals and try and help and improve mental health as we go forward. So I think rightly so, or understandably perhaps, focus has been on the transmission of the disease globally. And I think to get something like this under control, that's absolutely paramount. And I think that's understandable. But it has detracted from the psychosocial consequences of the outbreak in affected individuals and also the general population. And there are mental health issues that are emerging, which are relating to COVID and how we're living, and potentially can evolve into long-lasting health problems, particularly kind of to do with isolation and stigma, specifically for those who are more vulnerable in society. So a position paper that I'll talk about a little bit later in terms of the importance of researching mental health and kind of where we should focus has been published in The Lancet, which I'll go over in a little while. But in response to that, academics have said that actually we should also try not to assume that psychological responses to this health pandemic are completely different to other stresses, other adversities, or traumas that have happened before. And it's really important to pull on that existing research and existing evidence, so we're not reinventing the wheel as such. And even previous pandemics, there's literature coming out from that. So the extensive literatures on stress, adjustment, coping, and trauma, they can be drawn upon to maximize our understanding of the impact of mental health research. So as an example, I've pulled up on this slide the diathesis stress model of distress. So adopting that to this outbreak is, we can see that it's likely to either contribute to exacerbating mental health difficulties in those already experiencing psychological problems and illness, and also contribute potentially to the onset of problems in some individuals who are more vulnerable. So this model here on the slide, it can explain how a disorder can come about as a result of an interaction between the vulnerability of an individual and then adverse life events and the stresses it can put on that individual, and which will result in potential mental illness. When we talk about vulnerability, this can be genetic disposition, so a family history of psychiatric illness, those socio-demographic factors which we know can increase vulnerability in individuals, so gender, age, education levels, unemployment, also those negative psychological social factors, so how we cope, the style in which we cope, any past psychiatric history, comorbid psychiatric disorders, and also poor social support. So that's something that is particularly relevant at the moment with the concept of isolation and pulling ourselves away from our normal social interactions. So if a stress which becomes bigger than that individual's resources to be able to cope, that can result in the mental health problems and trigger illness or a worsening of the illness. So we've seen our society have to adapt to the government guidelines that were in the previous slide, and that's really resulted in a multitude of societal stresses. And again, these are not exhaustive, but there are undoubtedly more than this. But kind of job insecurity, job loss, huge financial strain. I hear endless stories of close friends and kind of on the news and everything about how this is going to really impact individuals. Isolation from family members, carers as well, and not being able to access the support. Homeworking and childcare, something I've definitely experienced with my 1-year-old. I've been in meetings bouncing him on my side and trying to dance, keep him quiet whilst I'm having a chat. So frontline staff as well, having quite a unique experience in these this situation and that exposure to illness. Children in isolation, those living in poverty, we all know about holiday hunger and how holiday hunger has in fact been for the last 4 months, and some real worrying situations there. I also do some work with a pupil referral unit for excluded children, and that's a real worry where the school have not been able to keep contact with the children in that school, and kind of their situation with gang affiliation, etc. And that has been exacerbated with school closures. So towards the beginning of the pandemic in the UK, the MQ and the Academy of Medical Sciences launched a survey, and this was 2 surveys. One was for stakeholders, which included those who have lived experience of mental health issues, mental health, healthcare professionals and carers, researchers, and also the general public. And nearly 2,200 individuals completed that, and there was 4,350 concerns submitted, and 70% of those who did participate had existing mental health problems. And those 2 questions which were in this survey were about asking what top 2 concerns and questions did they have around mental health and well-being in this current pandemic, and what were they doing to try and help their well-being in that time. And then the second survey was a general population survey, which again, 1,100 people were interviewed as part of this. And similar questions: what were their current thinking around the coronavirus and concerns about their mental well-being, and also trying to understand how those individuals were supporting their own mental well-being during that time. And this was for the general population. So 5 priority concerns were came from those surveys, and this led to the aim of this was to recommend some research priorities for mental health sciences. So anxiety was kind of all pervasive in this, and it was dominant in both surveys, and that was anxiety for the individuals themselves, but also for the family, and particularly family members dying. Worrying about others, people not complying with the guidelines was a big concern, and how that would contribute to the spread of the of coronavirus. Repeated compulsion consumption of media, and I think this is exacerbated in this kind of situation. We know that too much access to kind of the media looping is, or that consumption to always access media, can be detrimental to our mental health. And here, when we had daily briefings, you're in the house and there's looping about the news about the virus, plus on social media, trying to sift through accurate information from the misleading information, it can be quite difficult when we're not sure what we're looking for. There's widespread uncertainty about how to manage and cope with anxiety and support others, overwhelming uncertainty relating to the pandemic itself, and how this might worsen already existing anxiety issues. And then anxiety of those things that we've mentioned, those stressors on our lives currently, so finance, employment, getting food, medication as well, and particularly housing, which was lacking outdoor space, was pretty prominent. Also isolation, we're being told to isolate. People with mental health issues tend to withdraw from society, so that can only exacerbate things further as we're being told to isolate. So what is the impact of self-isolation on individuals? Social distancing, and when social activities that some individuals rely on. So some of the work that I did with Mind, we had quite a lot of individuals through the qualitative work that said that their social activities were the only times that they would see another person in any one week. So people do rely on social activities, and they stopped. In-person psychiatric support or psychological support, a lot of sessions stopped in person and were delivered online, and people were worried about the impact of their treatment and whether they would get the same benefits. Loneliness as well, so we can be in isolation and not be lonely if we have support and those social connections, but loneliness and feel trapped in one's house was a big concern, and that is detrimental on our mental health. Becoming ill as a consequence of the pandemic was a big fear. unwell physically, contracting the virus, but also becoming unwell to do with mental health. And the uncertainty, loss of control during this uncertainty was a big fear of death, and the fallout of bereavement as well, kind of going through that if anybody they knew became ill. Access to mental health services, there was deep concerns about how people could access their services, where services were stopped, potentially services not being a priority in that time, as I mentioned, and healthcare or mental health services worried about their clients as well. And also this is extended to other vulnerable groups. So those with learning disabilities, homeless, pregnant individuals, those in poverty, children who are missing school, missing exams, etc. And also family and relationships. So fears of family contracting the virus, anxious about the implications of any family members who were dependent on that individual, or they were dependent on as well. So these are the 5 priority concerns that came out of that survey. So this is the position paper, so the research priorities for mental health. So this position paper highlighted some specific areas that need attention, and it stated that this should be done as an international collaboration. So this is it's a pandemic, it's affecting worldwide, and this should have a global perspective. And also importantly, and David mentioned in his about how he's developing an intervention in the home, co-created. So this is something that is gaining traction and really important in terms of interventions, is that it should involve people who have lived experience of mental health themselves. They are the experts in how they are feeling, how they are coping, their needs as well. So that's particularly important. So the areas that were highlighted were the mental health effects of COVID on vulnerable groups, brain function, cognition, and patients who contracted COVID. And also what can be done to effectively mitigate mental health for these vulnerable groups. So another response to this position paper, if you want, were from a group of authors who stated that vulnerable groups is quite right, and actually stress that for those from the Black, Asian and minority ethnic groups who are already at significant mental health inequalities, this should warrant specific focus. And we know how this group were also potentially more at risk of contracting the virus in a severe way. So it's important to have a specific focus on specific vulnerable groups as well. That repeated media consumption, again, needs some focus about how to effectively control or give advice on how to control that media consumption for the individual, and those health messages, and what are the accurate health messages, and how can we sift through those more effectively. And then interventions, again, to address psychological, social, and neuroscientific elements. Okay, so mental health and severe COVID infection. So individuals who've actually contracted the virus, there's been some existing research on the impact of other coronaviruses and pandemics, and this has been reviewed to try and give some information and pull on those existing information to compare for the COVID. And this review concluded that if the infection follows the current COVID, follows a similar course to that of SARS and MERS coronaviruses, most patients should recover without experiencing mental illness, but acutely they may experience some delirium when they actually are in that period of time when they are experiencing the symptoms, and particularly kind of a severe COVID infection. But how healthcare workers and clinicians should be aware of the possibility of those individuals having depression, anxiety, fatigue, and PTSD. There is a possibility of that kind of in the more longer term. So that's kind of a different population group. And also frontline workers and mental health problems. So this is a particularly unique and specific risk of mental health problems. So research that has come out of Wuhan, some of the earlier research to do with this pandemic showed that medical workers, they were dealing with high risk of infection, inadequate PPE, they were overworked, frustrated, experienced discrimination, had to isolate themselves from their family members as well, had experiences of patients with negative emotions themselves, a lack of contact with the family, exhaustion. And this was resulting in mental health problems of stress, anxiety, depressive symptoms, insomnia, denial, anger, and fear. So pulling on previous outbreaks of Ebola in 2014 and 18 and SARS of 2003, medical staff reported high levels of anxiety and stigma, particularly those who were in contact with the individuals who had the virus. And staff in emergency departments and on the wards specific with the virus did develop PTSD. So it's really something to be aware of this unique population of the frontline workers who are really dealing with that intense situation to do with the virus. So going back to the survey, so individuals who were asked how they were dealing with their mental health problems, and the MQ survey revealed that individuals were doing certain things to try and protect their mental health. And each thing that came up, so you can see staying connected, keeping busy, staying calm, information intake, maintaining routine, and physical activity. And each of those things can be linked to existing research that shows effectiveness of these elements of how we can protect our mental health or try and improve our mental health. So staying connected, which is part of that 5 ways to well-being, staying connected to others, one of those 5 ways to well-being, which is really important. And whether that's physically, which we haven't been able to do quite so much until very recently, or online virtually, which there's been a lot of help and improvements in that sense to be able to do that. Keeping busy, so trying to reduce elements of rumination. So trying to reduce that time that we can we're going over and over the same thing, which will exacerbate anxiety. Staying calm, linked with mindfulness, and how practicing mindfulness can induce feelings of calmness and keep that for extended periods of time if we do mindfulness regularly. Again, going back to that information intake, so media consumption and mental health, kind of a really important one, particularly when there is so much information. Again, like I said, sifting through what is accurate and what is not accurate, and how that impacts our mental health, and the compulsion to continuously go back and get any new information that's going. And it's part of feeling in control. And in that sense, feeling in control, maintaining a routine is really important when we've been in the house. As David said, that time when you can go for a walk, maintaining a routine and stability within your day can help to maintain that personal control, which I think is really easy to feel like we're losing control of our situations because we're being directed to live in a certain way. And then physical activity was a real prominent one, and how that can influence our physical and mental health. And interestingly, a lot of these can be linked to physical activity. So maintaining routine, adopt physical activity, staying calm. So using mindfulness, we have certain modes of physical activity. So Tai Chi, which has been shown to increase feelings of calm whilst doing the exercise itself. Reducing rumination. So any physical activity that requires concentration has shown to reduce rumination. And exercise for those who have mental health problems can be a time where they can escape those ruminating thoughts. And staying connected, again, physical activity is part of that. Okay, so how can we mitigate that pandemic of serious mental health disorders, as The Guardian put it? And I'm going to talk a little bit about exercise as medicine now, and the idea of exercise as medicine. It's a popular concept, and it was pushed by Salas in the 2000s. Primarily, it started with physical health issues about how you can prevent several diseases through physical activity, with the advantage of not generating any adverse responses compared to drugs, and it being low cost. So in the context of mental health, then current treatment of mental health symptoms revolves around medication and psychotherapy. And these are effective, so there's a lot of evidence to show kind of that these are effective interventions, but they don't improve physical health. And in some cases with drugs, there can be weight gain, lethargy, which can kind of exacerbate issues further. And going back to the last slide, where I said exercise can fit into a lot of those, thinking about medication, that can't do those things. So exercise itself is good, but what all those factors that exercise brings with it is really important as well. So the evidence is now pretty convincing that physical activity can improve positive and negative symptoms of mental illness, and also benefits those predictors of mental health problems like stress, which is kind of really prevalent at the moment through COVID. So I created this mind map a little while ago, looking at the psychosocial benefits of exercise and that relationship between exercise and the mediators to exercise, and that relationship with physical activity. And I think if I kind of highlight some of the things that I've already spoken about, that you can see it's really related to the pandemic, and it's part of that complex relationship. So those mediators, so exercise, if it can improve social affiliation and relatedness, if we're doing it in connection with a community, and that will reduce isolation, which can reduce stress, anxiety, and improve psychological well-being. We heard from David as well that exercise can directly improve sleep, which again will improve our psychological well-being. But of course, it's important to acknowledge kind of the moderators in this, so demographic variables, any symptoms that those individuals are experiencing, comorbidities, and also thinking about the context that that individual is living. So as I mentioned, I'm working in psychiatric units, and in lockdown, any exercise sessions have been stopped. They are on skeleton staff, where many people have had to self-isolate, and whole wards have had to go into lockdown to try and prevent patients getting the virus. So thinking about the context that the individual is living, kind of going out and doing exercise might not be possible. So of course we've got these kind of that mind map, but it's important to understand those moderators as well. And just quickly, when I talk about exercise and medicine, it's important to highlight that we shouldn't assume that exercise is the answer for everybody. This paper here, which is a really interesting read, and I do recommend reading it, is from colleagues both at Loughborough and also at Leeds Beckett, which highlights that exercise is medicine most of the time for most, but not always for all. And if we think about individuals with chronic pain, potentially, which goes hand in hand with mental health problems, exercise may not be the perfect solution for that individual. And I think it's really easy to advise individuals to exercise to improve mental health. However, despite that convincing evidence that we've presented and David's presented before me, people with mental health problems and mental illness are significantly less active compared to the general population, and tend to engage in significantly more sedentary behaviour. And these individuals experience, and this is in normal times, I say normal, I'm not sure what normal is anymore, but these individuals experience a number of exaggerated barriers to exercise in kind of the normal times, or the best of times, I guess, which are only going to be harder during lockdown. So low mood, low self-esteem and competence, stress, health status, lack of energy, medication. And I've just split this up into kind of 3 categories. And the social, where we think lack of social or professional support, and some support has been stopped or changed in how people can access support. Isolation as well, that's a real barrier, and we're being told to isolate ourselves. And similar, those lack of resources to be able to go and access facilities which have been shut is just further exacerbating these barriers that the individuals are experiencing already and find more difficult to overcome. And that lack of priority given to physical activity, potentially in different contexts, as I mentioned. And many of these desirable outcomes of exercise, so mood improvement, stress, reduced stress, increased energy, they are inversely related to some of these barriers, so depression, stress and fatigue, all that restrict participation. So it's easy to say, yes, we can recommend going out to exercise, but we need to think about those barriers that people are experiencing, and particularly at the moment, they are exacerbated. Lack of motivation is also another barrier, and more than ever, now it's important to improve the motivation of those who need it to go out and exercise. So a theory that I work with quite regularly is self-determination theory, and this theory suggests that it's the quality of motivation which is important over the quantity of motivation that we have. And I've just kind of illustrated here the continuum that the theory proposes of how we have autonomous motivation right down to controlled motivation. So autonomous motivation is where we love doing something, so we enjoy it for what it is. And I think we can all agree that if you enjoy something, you're more likely to do it, and it's more likely to make you feel happy and improve your psychological well-being. But also what's beneficial for that better quality of motivation is when you can see that engaging in an activity is important. So those outcomes that you achieve through that are important to you. So whether it's improving your health, or being social around it, those things are important to you, so therefore you will carry on. And then at the other end, we've got more kind of controlled motivation, which is leads to more maladaptive outcomes and lapsing in physical activity and a lower psychological well-being. So if you think about an individual might say, oh, I should be exercising. They don't particularly want to, but they feel like they should. And it might not result in sustained physical activity, or they have to. They have been told by a healthcare, a GP, that they should go and exercise, and they've been told that they have to, not that they want to, but they have to. And if they then go and engage in that exercise because they want to take seriously the information that's been given to them by their GP, so they want to respect what the GP has said, but they don't particularly want to, that can exacerbate any internalized feelings of pressure as well. So that individual may have experienced feelings of guilt because they should be doing it, they don't want to, but they don't want to let anybody down. So thinking about that good quality of motivation is what we should be achieving for sustained physical activity, but also for improved psychological well-being. So now moving on to, for the last 10 minutes, some practical considerations for mitigating mental health issues through physical activity. And there are more than what I'm going to talk about, so I'm just going to pull on kind of my area of research to give some advice here. So the three things that I'm going to talk about is creating a supportive socio-contextual environment. So thinking about how we can promote that good quality of motivation. Optimizing the physical environment in which we exercise, and also reducing social isolation. And how reducing social isolation can also improve our motivation to exercise. So going back to the theory that I use, self-determination theory, part of that theory proposes that we as humans, we all have these innate psychological needs that when they are satisfied, we are more likely to have that higher quality of motivation, and we are more likely to have positive psychological well-being. So the first is autonomy. So if we have a sense of autonomy, we have a sense of control over our behavior, we are making the choices, we have ownership over what we're doing, then we're more likely to feel well about that. I think we can all kind of relate to some things in our own lives, that when we have control over that, we feel better about it, and we're more likely to do it as we choose to do it. There's also competence, so feelings of effectiveness in one's interaction with the social environment, but also feelings of effectiveness in achieving those valued outcomes. So those outcomes that are important to us, being healthy and being physically active and engaging with others, if those are important and you feel effective, that you'll be able to achieve those, you will get a sense of competence. And relatedness, feeling connected with others in a respected and secure manner. So that is really important for our mental health, that we are feeling connected, but that we feel valued as a person. So that connection has kind of a respect, a mutual respect, and it's a secure connection as well. So there are certain behaviours that individuals can take on to try and support and facilitate those needs, and try to enhance the individual's psychological well-being or enhance their behaviour, to maintain their behaviour. And often the research has shown that it's an individual in a position of authority that can provide these kind of behaviours. And that could be an exercise professional, potentially a GP, researchers, teachers can take on these behaviours as well, coaches, etc. And so to try and facilitate autonomy, so providing a meaningful rationale, so the individual understands why they should engage in that. So they might be told that they should, but why should they? Can they make their own decision and enhance that perception of the value of the activity? And provide a choice and a variety, so that individual can choose what they want to do within that variety, if they know what is available, and they can choose something that is more enjoyable for them. Like I said, if you enjoy something, you are more likely to carry on and do it. So with regards to relatedness, so providing that social support, and how can you do this in a trusted manner, to show understanding, to show care, acknowledging negative feelings, and particularly when we're talking about those with mental health problems. They might have negative feelings towards physical activity, may not feel like doing that every day, and that's okay. And it's important to acknowledge those, and then understand, okay, how can you overcome barriers to those feelings or to exercise, and how can that individual learn to overcome those barriers themselves? So it's easy to tell someone how they can do, but they need to decide on what is they're able to, and what are they competent at, or do they feel competent to be able to overcome those barriers. Trying to enhance confidence and relevant feedback and to enhance competence is really important. Helping those to set realistic goals, obviously, that they need to be achievable. I'm focusing on intrinsic goals. So this is really important. So when you want people to engage in physical activity, and this is predictive of long-term physical activity engagement, and for intrinsic reasons, so for health, for enjoyment, for personal growth perhaps, rather than those extrinsic goals. So weight loss is very much an extrinsic goal. So why, if an individual does it for weight loss, but then they lose a bit of weight and then they stop. So you want kind of that maintenance to happen. Okay, so how can we kind of mitigate that? So we created that social environment, which is really important, that an individual can try and facilitate for others. Okay, so how you can talk about exercise. So this study that I've got here is a study that I did a few years back, actually, looking at how we can use text messages to get that message across in a supportive manner, trying to facilitate those 3 needs to increase motivation. So this just shows kind of in the period of COVID, of a pandemic, that you can achieve those messages. It doesn't have to be in person, but actually using text messages can also be successful. So in this study, individuals did perceive support through the text messages, and this led to more physical activity behaviour, and that was sustained for a 3-month follow-up as well. So individuals commented that they perceived that text message coming from someone. So that kind of vehicle of the social support was there, so they were able to have a sense of that. And another study that I've been involved with, and this is specific to HIIT, so it's existing evidence that I'm trying to pull on rather than specifically to COVID. So it's looking at HIIT, and it's looking for individuals with type 1 diabetes. But the key is that it was in a home-based setting. And it was virtually supervised. So in a context like COVID, this is something that's very possible. And individuals adhered. This was a multidisciplinary evaluation. So we had some psychological measures and qualitative work in here as well. And individuals adhered to the program because they felt part of a community. So they felt connected within this home-based exercise. And there was a lot of body weight exercises which were achievable, and the challenges increased as the weeks went by. And this was very much for individuals who had type 1 diabetes, were largely overweight or obese. So the exercises took into account their capabilities as well. So I think the type of exercise, the message here isn't necessarily the type of exercise, but it is that can be done in your home and virtually supervised. We've heard about all the kind of fitness gurus doing their programs online, and the success that they've had over the last few months. And actually I'm involved in a study that has been written up looking at the comparison of these very research rigorous protocols for exercise programs versus the media-based ones. And the more pleasant feelings that the individuals had were actually with the social media exercise programs. And this was largely because it was delivered by a person and they were having that connection with an individual in front of them. And bear in mind, this was compared to kind of the lab setting, so which isn't particularly pleasurable at the best of times. Okay, so then the third thing that I wanted to touch on is the effect of the physical environment and the levels of activity on our affective states. And when I talk about affective states, it's the pleasure or displeasure that we're feeling at any one time, kind of acutely. So this study looked at immersing the participants in a green space, also watching green space from inside a lab, and that was compared to doing that sedentary and doing that whilst being physically active, and also compared to urban environment. So physical activity was the real key here, and that was whether you were watching green space or immersed in green space, you were getting those positive effects in terms of pleasurable feelings. And we know that green space is good for restoration, so improving our energy levels, reducing our fatigue when we're looking at that green environment, which is enjoyable to look at. It can have those restorative properties. And so this was very much true, and it was exercising whilst fully immersed in that green space, which was really key and had the biggest impact. So exercising in green space can improve our acute pleasurable feelings that can protect against mental health problems through the sense of restoration. People felt calmer and they felt less fatigued. So there are a couple of kind of examples of what we can do. So those key messages, not the key take-home messages, because we're all at home already, and those key messages that I've spoken about today, just coming up to 45 minutes and bang on time, is that mental health problems relating to COVID are all pervasive, and they really do include some complex societal issues. But it's important that we use the existing evidence to help inform, as well as that emerging evidence of this specific pandemic, this specific virus, and how we are living kind of really new experiences and those stresses that are being put onto our lives. So it's important to pull on existing evidence as well as that emerging evidence to understand how we can and improve mental health problems which are associated with COVID. And then engaging in physical activity has the potential to ameliorate mental health problems which are associated with the pandemic. And we can do that in certain ways. Again, this isn't exhaustive, but it's part of kind of where I'm coming from in my research, is creating a virtual social context, one which is supportive of those individuals' psychological needs, and then immersing ourselves in green space. And if that's coupled with walking with a friend at social distance, then even better. So thank you very much for listening and staying with me for the 45 minutes. Here's my email. Please feel free to contact me if you have any questions, and I look forward to any questions now. Thank you.
Brilliant. Thanks very much for that, Flo. It was really interesting. Nice to sort of round up the 4-week session with the talk about mental health, which we haven't heard about up until now. Esther, do we have any questions that have come in?
Yeah, we've got a couple of questions that have come through for Flo. So the first one is from someone who's a physiotherapist working in an adult acute mental health hospital, who's wondering whether there are any particular activities you would recommend to increase individuals' physical activity levels to achieve benefits in terms of mental health and physical health, considering the restrictions that are associated with COVID-19.
Yeah, absolutely. So I've got a couple of PhD students who are working in the psychiatric secure units, which have been really impacted actually by the lockdown. So it's, I mean, these environments are restrictive anyway, but even more so. And kind of those structured exercise sessions have been stopped to try and minimize any risk to COVID. So I think the important thing, so individuals who are on the wards, to reduce the sitting time. So that is what we heard from David. There is a lot of sedentary activity that happens on the ward. So trying to break up sitting time. What can you actually do on the wards? You know, simple things like even having any magazines which are one end of the ward, which are not next to the seating end, which means people have to stand up, go and get them and come back down. And it breaks up that sitting time, which is really important. Obviously, it's really, it depends on the individual in terms of kind of their care and their restrictions as well, about whether they can leave the hospital and have ground leave potentially to go for walks. So that's something that can be done. Any consultations as well can be done walking. And potentially, so if you want to have a chat with someone and say, come for a walk with me while we're doing the chat. And if you want to try and get the wards together, even group things, so sit into stands. So there's a lot of seats in wards generally in the hospitals. So can everybody work together and do kind of, I don't know, 10 sit to stands and trying to engage everybody together as well. So you've got the individual and you've got the group element. Again, peer support is really important to get people on board. So yeah, hopefully that's a few ideas.
Fantastic. Do you know, has there been any research on mental health for housebound people watching television programs about the countryside as opposed to going outside?
Watching programs about the countryside.
Yeah.
Did you say? Yeah. So absolutely. So the study that I did specifically was looking at it wasn't individuals who were housebound. So I think coming from that reflection is important to know the difference, that these were healthy individuals who just came in to be sedentary, but they were just watching videos of green space, and that did improve their pleasurable feelings and reduced feelings of fatigue. So there has been research done in terms of being sedentary and watching green space and the benefits that has on mental health, positive benefits in terms of restoration. But specifically for that population, having done the research with that population, I don't know of any specifically.
Okay, that's really interesting. How long would you expect anxiety or wider metabolic health problems to last, even after things go back to normal after the lockdown?
I think this will be really variable, and it will be really variable on individual context. It's individual context of kind of what has been happening to that person, but then also thinking about their ability to cope, and then any support that they're getting, it will. So I think potentially it could be really long lasting, and for some people it might be quite transient if they can get the support, if they have their kind of personal resources, can cope and be resilient over it. So I think it's a real individual context, which makes it even more complex. I think there's definitely not a one size fits all solution to it.
Okay, and the last one that we've got at the moment, what do you think are going to be the most worthy areas of research over the next 6 months?
Good question. This is my, I've been thinking about this, I think it is, so in terms of my research, where we'll be going, so we've been developing interventions in certain situations, and a lot of these situations have had to make big changes. So I think it's trying to understand how you can continue promoting physical activity. I'm thinking physical activity specifically here, how you can continue promoting physical activity when the world changes. So, when it changes dramatically, okay, what can work in all those different situations, and how can you adapt certain things. So I think that will be really important to, you know, continue trying to get people to be active. Like David said, it's really easy to stop. I know I've caring for my little guy and trying to work around his care, I've definitely become more sedentary. Not sedentary because I'm running around after him, but engaging different types of exercise, let's say.
Right, I think that's all the questions that we've got for Flo at the moment, James.
Brilliant. With any more for David?
There was one for David. So how does a loss of lean mass impair immunity and infection risk?
Yeah, in terms of cause and effect, obviously very difficult to establish, but we can often associate loss of lean body mass as well with malnutrition and poor diet quality, energy intake, as well as getting all the essential vitamins and minerals that we need as well, that can actually increase that risk of infection.
We can extend the question that was asked to Flo to you, David, about you were given £500,000. What is the priority research?
I mean, that's interesting. As soon as Flo was asked that question, I thought about that myself, and I think from a research perspective, in terms of research that I'm interested in, it's how we help and support probably thousands and thousands of people that are going to put on weight, to help them lose that weight and maintain that body mass loss as well. I think that's key. I think, interestingly, you've got one of the most high profile COVID-19 sufferers in Boris Johnson, the Prime Minister, who even himself, stated that, I think I suffered from this thing more because of his BMI that was reported to be something in the region of 36, so definitely obese. So the government has got to act in terms of putting interventions in place and to help support people. And there's a clear role for exercise science and the work we do in helping to support that.
I guess with that, David, do you think it's one of the issues is it more policy? Is it grand changes to society, or is it sort of all bespoke interventions for different groups?
Yeah, I mean, everybody has a responsibility for their own behaviour, for sure. But I think, the environment that we live in, plays a real big factor. And I think it's almost about having opportunities, and Flo alluded to this in her talk, is, we need to enjoy physical activity. Physical activity shouldn't be seen as a chore. It needs to be seen as play. It needs to be seen as fun. So I think we just need to create that environment and those opportunities for people to do physical activities that they enjoy. And of course, there has been, real examples of that. Again, I know I like to reflect on personal experiences, but during the Thursday when we were clapping for the NHS, our street, we went out on the street and we were clapping, and then someone put a load of music on and everybody was just dancing in the street. So it's just about creating that fun factor. It's about creating that social movement.
Brilliant. We've just had one question come in, which I don't know if Flo or David is the best to answer this, but
probably Flo.
The question's about exercise with regards to reducing tiredness. If you know if there's any research around the topic.
I'll try and answer this, and then I'll pass over to you, David. So in terms of what I was talking about, in terms of restoration, and I always use the analogy of kind of when our brains are depleted like a battery, you have kind of low battery, and then you can immerse yourself in certain environments like green space. And if you are focusing on certain elements of green space, so some properties of that, if you focus on those without much effort and they are pleasurable to look at, then it can kind of restore that battery that you've depleted throughout the day. So that is in terms of kind of where you immerse yourself. And then with physical activity, again, it's different with individuals, because I have done some research with people with mental health problems, and some people actually exercise and get then so exhausted that it sets them back huge amounts. So I think it's important to be, when I talk about exercise as medicine might not be for everyone, I think it's important to consider those individuals. But again, kind of that that feel-good factor of exercise has been reported to reduce the sense of tiredness in that person. So that person's perception of tiredness, if you want.
Anything to add, Dave?
Yeah, just, I mean, I think Flo's answered it there. Certainly, you know, physical activity through the release of various things like endorphins can lead to the pleasure experience. And I think what's key for me is, you know, exercise or be active when you know, at the best time of day for you, okay, and when you can fit it in and when you want to be active. Yes, routine is important, but if you get to a point where, you know, actually you do feel a bit tired and you don't feel that you'll get that quality physical activity, you know, actually just leave it and then try and pick it up later on in the day or the next day. I think also what we have to be very mindful of as well in terms of balance and in terms of tiredness and fatigue as a phenomenon, it's really, really important not to overdo it. Certainly if you are beginning, you know, exercise and physical activity, you have to build up gradually, start at a low intensity and progress, because there are some obviously negative experiences associated with exercise and, say, resistance training. For example, DOMS, delayed onset of muscle soreness. And if you've not got experience of activity, suddenly you go into doing an unaccustomed exercise or activity, you experience DOMS, you're going to experience pain for a couple of days afterwards. That could potentially put you off. So, you know, start and build up gradually.
Brilliant.
I had one more question come in for Flo. How would you recommend getting healthcare professionals to recognise the benefits of physical activity within the mental health sector, as it's still very much based on a medical model with medicines rather than a biopsychosocial model?
Well, I feel like this might be a planted question, but this is really relevant because that's exactly what my PhD student is doing. So they are currently designing a online module for healthcare assistants on how they can promote physical activity. And we did some research to try and understand the perception of healthcare assistants in terms of their understanding of exercise and what their role could be. And actually we thought that they really are best placed to try and encourage physical activity, or be some the people who carry those messages, because they have the rapport with the patients and they are with them for so much of the day. And so again, it's taking on, when I was talking about those kinds of behaviors or those kinds of ways of talking about exercise, this is really important that those individuals, healthcare assistants in this case, can take that on. So my PhD student is designing an online module that can be done. This is specific for an induction for people who are starting in a secure setting, that they can be done as part of the induction to really educate the healthcare assistants about exercise, because I think a lot of people know that exercise is good for us, but don't understand what they can say to the patients, or how much exercise, or what can that exercise be. And a lot of perceptions of exercise is you need to kill yourself in the gym to get any benefits, where actually that's that's not the case at all. So even just reducing sedentary time, so cutting up sitting is important, and we need to know that that is also part of it. So going out for walks when you can is important, and it's okay. And I think also it came out that healthcare assistants weren't confident in giving those messages because they weren't sure what messages to give. And also sometimes that wasn't their role, that it was the role of the exercise professional or the exercise therapist. So it's understanding that physical activity does come under that well-being umbrella that they're kind of responsible for, as well as kind of eating well, hygiene and the rest of it. So thanks for an excellent question. I could answer that one.
Brill. Is there any more, Esther?
That's all from me.
Okie dokie, then we're nearly at 8 o'clock, so I think we'll conclude it by thanking Flo and David for giving their time and giving 2 fantastic presentations. I should say that within a few days, the talks will get uploaded as videos onto the National Centre webpage, and they are tucked away, but they're under the sort of the education and CPD link, so you can find them there. And because this is the last session, there's an email address there for Alison Stanley, so if anybody has any suggestions for further talks going forwards, we obviously will try and increase the programme, but if anybody wants to say anything in particular, please do feel free to put suggestions forward, and we'll do our best to try and get somebody with some expertise to put some slides together. So yeah, thanks everybody, and we'll leave it there.